Hello and welcome to another psychology revision video as we do depression, and it's all very exciting.
Yes,
isn't it?
It is exciting.
Today we are doing the characteristics of depression, part 1 of our video series of 3.
So, the first part of depression you need to know are the symptoms from the DSM-4, even though the 5th edition has already been released.
Now, there are 9 characteristics, and for a diagnosis you need 5 or more, including one from the first 2 sets of symptoms for at least 2 weeks.
The first is extreme sadness, tearfulness and depressed mood.
The second is loss of interest in and pleasure in usual activities together with social withdrawal.
The third is disturbed sleep, either loss of sleep or more sleep than usual.
The fourth is changed activity level, often agitated or maybe slowed down and lethargic.
The fifth is disturbed appetite and weight change, which can either be significant gain or loss.
The sixth is tiredness and loss of energy, more generally than number 3.
The seventh is negative self-concept, including feelings of guilt, low self-esteem and anxiety. Don't combine this with number 1.
And the 8th is the one most people forget, difficulty making decisions and diminished concentration span.
And finally, the 9th is suicide attempts or recurrent thoughts of death.
So sadness, social withdrawal, sleep patterns, activity, appetite, tiredness, low self-esteem, decisions and suicide.
So get remembering.
Now, as you should know from research methods, reliability is the consistency of a measurement.
One way of assessing reliability is to present the same case study to a variety of clinicians and assess the extent of agreement, which is inter-rater reliability.
Or you could see whether the test gives the same results on 2 different occasions. This is test-retest reliability.
For depression, you need to know evidence assessing the reliability of major depressive disorder or MDD.
One study carried out a multi-site study to explore the reliability of the DSM-4 classification for MDD.
They recruited 524 depressed individuals from 5 different sites.
Each was interviewed using the DSM criteria and interviewed again 6 months later to establish test-retest reliability.
Results showed that inter-rater reliability across different sites was fair to good, but a 6-month test-retest reliability was poor to fair for major depression.
This supports another study which found an inter-rater reliability correlation of 0.80 for MDD and a test-retest correlation of just 0.61 with 1 week between diagnosis sessions rather than 6 months.
For MDD to be diagnosed, as we've said, you need a minimum of 5 out of 9 symptoms.
And when the severity is such that it's just at the diagnostic threshold, a 1-item disagreement makes the difference between a diagnosis of major depressive disorder and a less serious illness.
This could be the reason why the DSM diagnosis of depression might lack reliability.
Now, on to validity, which is the extent to which the categories say something basic about the disorder, or the accuracy.
Establishing validity is more problematic than reliability because there is no absolute standard by which diagnosis can be judged, so no guarantee particular diagnosis will be correct.
There are 5 issues which we intend to raise, and you can in your essay relating to depression diagnosis.
Are there any distinct types of depression?
The diagnosis of depression requires clinicians to differentiate among several distinct subtypes.
But one study compared 681 patients with various types of depression, including major depressive and dysthymia.
They found a considerable overlap in symptoms, responses to treatment and other variables, making it difficult to justify distinct forms and suggesting the different subtypes aren't valid.
If you really want to show off, you could inform the examiner that dysthymia has since been reclassified into a more general form of depression, with some other subtypes in the most recent DSM.
Yeah, the 5th one. So that in itself really proves how valid the diagnoses were.
Are GP diagnosis valid?
For most people, a diagnosis of depression is given by their GP.
One study suggests that diagnosis by GPs, as opposed to those by specialists, may be objective because they are based on previous knowledge of the patient rather than actual presenting symptoms.
So the symptoms needed for the DSM diagnosis.
Is depression overdiagnosed?
One criticism of DSM validity is that its criteria do not separate psychopathology from normal unhappiness.
In fact, the DSM definition is so broad that most people will meet it at some point.
One study found that up to half of all people meet criteria at some point in the first 32 years of their lives.
This is concerning as if many normal behaviours are diagnosed unnecessarily, it may lead to overuse of antidepressant drugs, which are frequently prescribed if MDD is diagnosed.
There are two factors which contribute to the issue of overdiagnosis.
Firstly, how major is the major depression?
The DSM requires 5 out of 9 criteria, but do note that there is no real research evidence for this. They just picked 5 because it's more than half of 9.
A diagnosis can be made on the basis of milder symptoms, low mood, loss of pleasure, loss of energy, reduced concentration and insomnia.
Some research found that all of these occur in transitory model states in response to environmental stresses in the normal population.
Another study found that the use of the 5 out of 9 methods lacked validity, as when researchers reduced the threshold to only require 3 of the 9, it didn't alter the diagnosis of patients.
So, somewhat obviously, this suggests an issue with the 5 of 9 method.
The second factor is the short necessary period of 2 weeks.
Research has shown that after serious loss or setback in life, take like a divorce or job loss, most cases of mild depression disappear quickly.
So extending to 4 to 6 weeks could reduce overdiagnosis and overuse of antidepressants.
On to another validity issue. Is depression diagnosis cross-culturally valid?
An international study sponsored by the World Health Organization points at a common foundation of depressive experience in the different cultural settings.
They identified common elements in 4 countries: Iran, Japan, Canada and Switzerland. Sad effects: loss of enjoyment, lack of energy, loss of interest, inability to concentrate and ideas of inadequacy and worthlessness.
This suggests that there is a cross-cultural validity to depression.
But there is evidence that depression is expressed in different ways in different cultures, which may affect diagnosis.
Depression in non-modernised settings tend to be expressed differently and may escape the attention of a person who is of another culture.
One study showed in China somatization served as a typical channel of expression of depressive experience.
Oh yeah, somatization is the reporting of psychological problems in terms of bodily symptoms like headaches and back problems, etc.
Thank you very much for your little cheeky definition there. Love it. The Chinese rarely complain of feeling sad or depressed. Rather, they refer to the body.
This may mean that using the DSM with Chinese patients may not diagnose their depression.
And actually, ethnic minorities in the UK are less likely to seek professional treatment for depression.
This may be due to the stigma attached to mental illness in some cultures, or that members of those cultures tend to view depressive symptoms as social problems.
Individuals belonging to white majority view depression as disease requiring professional treatment.
And finally, is depression diagnosis gender biased?
In Britain, a woman is 40% more likely to be admitted to a psychiatric hospital.
And women are 2 to 3 times more likely to become depressed and are more likely to experience several episodes.
This could be because women are genuinely more likely to get depressed than men.
Or could it be that the diagnostic process is gender biased, overdiagnosing women and underdiagnosing men?
Well, we don't know. It's exciting. One possible gender bias issue is that one of the core symptoms is extreme sadness and tearfulness.
It's far more socially acceptable for women to cry, which may lead to underdiagnosis of men.
Some research has suggested that rather than talking about their sadness, men may turn to alcohol and or drugs, and this could lead to a diagnosis of alcoholism or drug addiction in men instead of depression.
Diagnosis of depression usually requires a visit to your GP, and research also shows men are less likely to visit their doctor, which again could lead to underdiagnosis of depression in men.
And that's it for this part. Join us next time when we do some cheeky biological. We're loving it. And then we got psychological after that. Hopefully I'll know how to say them by then. It's exciting.
Thanks for listening.
Amazing. Go listen to some other ones as well. No, that was very demanding. If you would like, you can go and listen to some other ones as well.
That would be lovely of you.
Thanks.
Thank
This
you.
has been WAHEY Productions. All Carne?
Ooh,
Sarah Carmen?
Yep.
Bye.
Bye.